Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Dr. Colin Richman was born and educated in Johannesburg, South Africa, and currently maintains a private practice of periodontics and dental implants in Roswell, Georgia.
Hello, I'm Colin Richman. I practice periodontics in North Atlanta. Some of you may know that about 15 to 16 years ago I became involved in this concept of orthodontics, and we've practiced this and it has grown intensively ever since. It now constitutes approximately 30 to 40% of my actual practice. I have previously done this presentation for the Seattle Study Club that was previously broadcast, looking at the benefit of orthodontics, or PAOO, in the adult community. We have since moved on with my orthodontist and myself to include a substantial amount of this type of treatment for the adolescent community. So, as I've discussed in the past, there are 4 major complications that are well documented in the literature and relate to post-orthodontic treatment of the crowded dentition. And these include gingival recession, orthodontic post-treatment relapse, apical root resorption, rejection of treatment plans by patients because of the time factors involved, and enamel demineralization. And to make this easy to remember, I've created the mnemonic of 4 R's and 1 D. The most important for us on a daily basis as periodontists is the element of gingival recession. There are numerous studies, if you search the literature, talking about gingival recession post-orthodontic treatment, and Renkemer has done a terrific meta-analysis, and as we all know, a meta-analysis is the highest level of evidence demonstrating the incidence of gingival recession almost up to 80 to 90% at the 20-year mark. Recently, Tatakis completed another meta-analysis clearly demonstrating to us that gingival recession is progressive, and thus, if we consider gingival recession as an etiological, as to what the etiological factors are, maybe we need to be thinking more proactively than reactively in treating our patients. Orthodontic stability, there are a number of studies demonstrating up to an 80% relapse, Little, for example, Roth, for example, in patients at the 20-30-year mark. Recently, Ferguson, on the other hand, demonstrated to us increased stability when corticotomies with augmentation treatment was provided. So, why do we have this gingival recession? And there's one narrative by Addy that talks about the fact that the gingival blood supply comes from the underlying alveolar bone. And any of us who have done any mucogingival therapy will see the middle central picture as a typical picture in the orthodontically crowded dentition. And you can see on this central picture beautifully that there is no blood supply coming out of the cemental surface. The blood supply is coming from the adjacent bone to the overlying gingival tissues. If you look closely at the right image, you might even see tiny lacunae out of the upper right skull image. But notice the difference between the alveolar bone of that crowded dentition versus the non-crowded dentition. So today, do we have preemptive therapies that will reduce or even eliminate the risk of these 5 post-orthodontic iatrogenically induced complications? And indeed we do, and this procedure, essentially of corticotomies and augmentation, in our community, I have coined the term POPA, which is pre-orthodontic periodontal augmentation for a number of reasons. But in all of these type procedures, we raise a full thickness flap, We then provide decortication. We then will provide substantial augmentation using a variety of different augmenting agents. We'll release the flap. We'll strive for primary closure, which is not difficult to obtain. And at the very same time, in order to exploit the wrap effect, we will institute orthodontic treatment. And in my opinion, the secondary benefit of this procedure is accelerated tooth movement, and that is what patients want. Certainly that's what our restorative dentists want. But the primary benefit, in my opinion, this is still to be documented, pertains to enhanced alveolar morphology, resulting in increased stability with decreased subsequent recession. That study is in the process of being collated and will be in press soon. And when we look at this, I think we need to be thinking of these patients as to what is the etiology of the crowding in the first place. Just to further consolidate our thoughts, this is a patient that I had an opportunity to re-enter. You will see on the left image, the blue arrow depicts the deep dehiscence defect. When I had to re-enter at a later date, that is the same tooth following corticotomies with augmentation. I was able to obtain a biopsy specimen, and we will notice living vital, typical GBR type of material. So let's talk about some cases in the adolescent community, and we are treating many 10, 11, 12-year-olds prior to implementation of orthodontic treatment. This is an individual at aged 8. He underwent primary first phase treatment, and the net result at age 11, 12 is the middle central picture. We then started phase 2 treatment. We provided the corticotomies and augmentation. What you see on the lower left is a very thin bone profile in this 12-year-old. We see very early dehiscence defects. On the upper right, we see the bony morphology prior to corticotomies and then 2 years later with grafting. The same patient, noting sagittal images through the same tooth with a 2-year differential, notice that increased thickness of alveolar bone on the B point area. And this is that kid's reformatted image showing the pre on the left and the pre on the right CBCT scan. And this, of course, is the occlusal view, noting that increased grafted bone. This is another patient. She's 16. She's got a severe class 3 malocclusion. She's headed for orthognathic treatment. We noted early recession on certain mandibular anterior teeth. Notice that those roots are sticking out of the alveolar bone with prominent eminences. We took this patient for a grafting procedure for the mandibular 10 teeth. You can see the tightness of the teeth, the root proximity problems in the upper right image. We see the alveolar bone at the time of surgery. Very thin dehiscences and some fenestrations are present. We notice now at 4 months post-treatment this thickened, terrific, robust mucogingival complex, tissues back to where it should be. The secondary benefit of accelerated tooth movement has occurred. That's a 4-month post-treatment. And all of this is predicated on 3D imaging and the use of CBCT scans on our patient. Notice this individual with the pre on the left and the post on the right of grafting on the lingual. And of course, Roth, in her seminal study from the University of Washington, showed that after 20 years, the thinner the B point was, the greater the risk of relapse. So how can we make such statements? Do we have evidence to support that? And the answer is absolutely yes. If you search the world literature, you will find innumerable citations in humans and animals pertaining to the value of corticotomy and augmentation therapy in our patients. And based on Tataka's study, I'm of the opinion that the earlier we graft and before recession starts occurring, that the earlier we identify the problem and graft it before recession occurs, the better the result will be. We've already got a terrific textbook by Brugnani that I would highly recommend on this topic, and it comprehensively covers everything that you want. So my final few thoughts are, why is there crowding and recession and impacted teeth and maybe breathing disorders? What is the etiology, and can we be proactive rather than reactive in treating the consequences subsequently? Well, in order to answer that question, we've got to go to dental anthropology and dental genetics. And when I can't sleep at night, that's what I do in my spare time. I read books on dental anthropology and genetics. And as you will see on the right image, that depicts the fact that this is familial and progressing with generations. So this image on the right demonstrates that many of us have now seen 3 generations of orthodontic crowding, subsequent recession, etc. And in order to answer these questions as to why, we need to go back to our ancestors thousands of years ago, at which time, in order to survive, we were out in the bush, out in the jungle, hunting our prey, killing our prey, fighting off our predators and survival. And you will see on those 2 graphics, the left represents our predators, where we had a small brain and big powerful jaws, and then we became wiser, we became farmers and gatherers and industrialized food production and microwave use and fast food use, and as a consequence of that, our crania have been expanding and our faces have been shrinking together with the associated alveolar bone. And there are a number of reports, one of which is referenced, a terrific one, which is referenced in the upper right. So as we've progressed from all fours to where we are today, we notice that our cranium is growing, our faces are shrinking. And why don't we ever see these problems in the animal kingdom? I've looked at over 1,000 sets of animal jaws from different planets, from different continents and museums around the world, and the incidence of crowding and impactions and recession, well, not recession, and crowding and impactions is virtually non-existent, because from the genetic standpoint, they are genetically homogeneous, living in their natural environment. We are on the right. The second issue associated with the decreasing volume of bone from a decreased functional perspective of muscle and bone is governed by functionality becomes genetic. Of the last 3 or 4 generations, New World countries, metropolitan cities have seen an incredible pooling of the pooling and mixing of the gene pools. And so if one were to imagine the great big football player, for example, of Scandinavian origin, and the little gymnast, for example, of Mediterranean or Asian origin, producing a child with his big footballer's teeth in her small little petite gymnast's jaws, indeed we have a problem. So in summary, as mentioned, to me the secondary benefit is accelerated tooth movement, because that's what our patients want, a facilitated movement of difficult to move teeth through the wrap effect. The primary benefit of the corticotomy and augmentation is providing the deficient facial alveolar bone, assuming that's the direction the teeth are going to move in, to these patients who demonstrate with that problem. So the message is, treat, in my opinion, treat the etiology and then correct the problems of aligning those teeth. As we finish off here, this is another young patient. We're speaking about adolescents Pre on the left, post on the right. This is what this individual looks like at the time of surgery. Thin alveolar bone. If we're going to move those teeth further facially, of course, we're going to worsen that situation and end up with problems. The CBCT scans for this individual are self-explanatory. So in conclusion, that is my business card. And one day I was sort of pensive and introspective, and I looked at that card and I said, is that really what I do? Periodontics, oral medicine, and dental implants, it's rather boring. Maybe I should change it. And this, of course, is tongue-in-cheek. We the periodontal community, are alveolar, and the oral surgical community, by the way, are alveolar bone mongers, building foundations to last, guaranteed to be termite-free with compliant patients. And we deal in new and used bone, human, bovine, equine, porcine, your choice. And maybe we should describe ourselves as periodontal tissue bioengineers. And finally, next time we are looking for dinner, maybe we ought to do as this pack of wild dogs have done, use our jaws to acquire our nutrients. That picture is courtesy of Stephen and Brennan Reimer. I thank you very much.